Good evening, everyone. Welcome to our first online Profs in the PAV. Shortly, I'm going to be introducing Sally McGill, our Chief Financial Officer and the university's lead on sustainability. However, if you have any questions for our professors during this webinar, please drop them into the chat and we'll be answering them at the end. Thank you, Sally.
Thank you, and welcome to our autumn series of Profs in the PAV, which we've been able to continue online. So thank you very much to everybody for tuning in. The theme for this semester is going to be to look at the UN Sustainable Development Goals as part of its own pledge towards environmental sustainability. The university has recently signed up to the One Planet Pledge and has committed to reducing its emissions to a carbon net zero position by 2030. The UN Sustainable Development Goals are embedded in our academic strategy and specifically in our research strategy. And obviously that's what we're focusing on tonight, is to hear about some of our research that's going on. So this evening, we're going to be hearing from Professor Chris Gidlow, who is a Professor of Applied Health Research, and Associate Professor Aoife Healy, who is an Associate Professor of Human Movement Biomechanics. And they're going to talk about health inequalities, which are a global concern. And the gap between the health of the richest and the poorest countries continues to widen. The first part of this talk will introduce the social determinants of health, in particular, the potential role of natural environments, before considering one of the most extreme forms of inequality, which is homelessness. The second part of their talk will then explore the inequalities of healthcare access. The global prevalence of non-communicable diseases such as diabetes is rising steadily, and this is linked to population growth, aging of the population, and lifestyles associated with urbanisation. Many of these people need access to mobility assistive products to allow them to actively participate in society, and it's estimated that only 1 in 10 people in need of that access to prosthetic and orthotic mobility assistive products actually have that. So can I also just say, before moving on to this evening's talk, congratulations to Aoife on her recent appointment as the Associate Editor of Assistive Technology, which is the official journal of the Rehabilitation, Engineering and Assistive Technology Society of North America. So congratulations, Aoife. And Aoife continues to work with Professor Nachi Chokalingam in this area of prosthetics and orthotics, and has recently conducted a systematic review which has been completed and has informed global standards for prosthetics and orthotics. And she and Nachi continue to be involved in various activities with the World Health Organization in the area of assistive technology. So I will now hand over to Chris, who is going to start the lecture. Thank you.
Okay, thank you, Sally, for the introduction. And good evening, everybody. Thanks for joining the session. As surreal as it is to try to do this online, we'll do our best. So my name is Chris Gidlow, Professor of Applied Research, as been said, and I'll let Aoife introduce herself properly when we get the second half of the talk. So I'm the Director for the Centre of Health and Development here at Staffordshire University. We were set up jointly with the 2 local authorities a few years ago with a focus of research to improve health, tackle health and social inequalities, and we do work across a broad range of areas related to that. As has already been said, this is the first in a series of talks aligned with the UN Sustainable Development Goals, and tonight is about Goal 3, and so I guess a lot of what Aoife and I do aligns best with good health and well-being. But certainly a lot of what I'm going to talk about also links with Goal 10, reduced inequalities, and perhaps 11 about sustainable cities and communities. But this is about good health and well-being first and foremost, and importantly, good health and well-being for all. And so how have we been doing globally? This graph shows over recent decades that things have generally been improving. So this is life expectancy from 1950 to 2015. And life expectancy is a pretty good proxy for general population health. And what you can see in the middle, it's a bit small, but hopefully you can make it out. There's the green line, which is the global average, and you can see life expectancy steadily increasing year on year over recent decades. And that trajectory is the same across the board pretty much. There are differences between countries. So at the top, we've got some of the higher income countries, including the UK, some of the lower middle income countries down at the bottom. But direction of travel is broadly similar. It gets a bit more nuanced, I suppose, when we look at these data, which are from this year from the World Health Organization. So these graphs this graph is plotting gains in life expectancy from the year 2000 to 2016. So across those 16 years, so whereas 0 on this graph is no improvement in life expectancy within that population. So each country is represented by a circle, and they are clustered by income level, from low income up to high income. And what's pretty apparent from this figure is that that overall global increase in life expectancy we just saw is largely explained by the pretty massive strides that we made in the lower middle income countries. We've seen increases in life expectancy and health in higher income countries, but it's the lower income countries where we've really seen those differences. And same is true for healthy life expectancy. So that is how long people can be expected to live free of chronic disease. And you can see again, we see the similar pattern of biggest gains in the lower income countries. And a lot of that is down to big improvements in infant mortality and under 5 mortality, and improvements in fighting infectious diseases, where until COVID, infectious disease wasn't necessarily a big issue, or wasn't a primary issue for us. In the higher income countries, it's more about the non-communicable diseases, your heart disease, diabetes, cancers, and so on. And I know Aoife is going to talk more about the NCDs in a bit more detail later on. So I suppose one main take home here is that things have been generally improving, most in the lower income countries, but differences still remain. So absolute wealth is important for health. The higher income of the country, the richer the population, the better the health in general. But we also know that relative wealth is important, the social disadvantage. And these are data from the recent Marmot review published this year from England. And we can see even in a fairly high income country such as ours, we see fairly sizable differences in life expectancy between those who live in the most deprived, the poorest areas versus the least deprived. And so in men, it's approaching 10-year age gap, in women getting on for 8 years difference. So this is what's called a social gradient in health. And the Marmot review also showed a sort of interesting and slightly worrying trend for life expectancy over the last 20 years. So what these figures show is at the top we've got males, and the bottom graph is females. And again, we're looking at life expectancy from 2001 up to 2017. From 2001 to 2010, you can see what we saw before, as in there's not massive but steady increases year on year, people are living longer. We get to 2010 to 2017, and that kind of plateaus. And actually, in the most deprived groups, women life expectancy has started to come down. So something's happened over the last 10 years to sort of put a halt on those, what we've become accustomed to, those year-on-year improvements in health and life expectancy. And actually, in some cases, we can see that these inequalities between those who are worse off in society and those who are best off are actually starting to increase at a faster rate in the last 10 years. And why is that the case? What's been happening? Well, I guess a prime candidate for that is 10 years, or approaching 10 years of austerity measures. So local authority budgets have been squeezed. There's been less public money for things like adult social care and other services. And not only that, but those funding cuts have been felt most keenly in the most deprived areas. So local authorities and councils who are serving the most deprived populations, where the health is greatest, the health need is greatest, have had their budgets cut disproportionately more than those in the less deprived areas. So that would seem a fairly strong candidate for explaining why things appear to be not improving and perhaps getting worse in this country. And that makes sense if we think of the social determinants of health. And I'll come back to that in a little bit more detail, but the social determinants of health model is used, and Professor Michael Marmot, the author of the review I've been taking the data from, he's used these to try and identify ways to improve health and reduce these inequalities. And it really sets out that it's not just about health and healthcare. It's not just about healthcare access, sorry. It's about all the other things that shape the conditions in which we live and have a profound impact on how we live and our health. And then it would be remiss not to mention the global pandemic in a talk around this at the moment, because COVID comes along. So we know that the burden of disease is disproportionately hard and has the biggest impact in the most disadvantaged groups. And then along comes COVID, and this figure taken from the UN Human Development Programme, sorry, shows the daily deaths from COVID compared with other major global killers of HIV, transport injuries, self-harm, malaria. And you can see it's quite substantial. It's kind of blows them out of the water during those periods from sort of April up to May this year. And from what we've said so far, we would expect that that will be felt disproportionately hard in the most disadvantaged areas. And that's exactly what data from Public Health England have shown us. We've seen a social gradient in the age standardised diagnosis rates. So the diagnosis of COVID has been higher in the most deprived areas compared with the least deprived. And we see this social gradient across, and again, this is for England. And the same applies to age standardised mortality rates from those diagnosed with COVID. Males and females, we see this social gradient where death rates from COVID are higher in the most deprived areas and lowest in the least deprived. And that sort of brings me to some of the work that we've been doing relating to health inequalities and COVID. And I suppose in one of the groups is one of the most extreme examples of health inequalities, where the deprivation is greatest and the health needs are greatest. And that's people experiencing homelessness and specifically rough sleepers. And so I'm sure many of you have seen this. It's got a lot of media attention, and rightly so, is the everyone in policy. So when in a bid to try and stop coronavirus transmission and reduce the impact of COVID-19, the government announced everyone in, which was the national policy to move all people who were sleeping rough into emergency accommodation, which was usually vacant hotels. And there was a couple of good reasons for doing that. And so first and foremost, it was to prevent transmission of the disease among people experiencing homelessness, among that population, and also the wider transmission to the wider general public. And rough sleepers clearly fell into a very high risk category for COVID because of the prevalence of co-occurring chronic health conditions. So something like 73% are thought to experience chronic physical health conditions, 80% mental health conditions, often more than one at the same time, substance misuse issues, addiction issues, lots of reasons why they're at high risk of experiencing serious and life-threatening symptoms should they contract COVID, but also difficult to prevent transmission due to often shared living spaces, perhaps unhygienic, lack of access to basic washing facilities and so on. And I suppose one of the most sobering statistics about this population, just as a general example of health inequity, is the average age of death for rough sleepers is just 44 in men and 42 in women, compared with 76 and 81 for men and women respectively in the national general public. So from 2010 to 2017, rough sleeping had risen year on year over those austerity years. Year on year, it's gone up and up and up. So a 250% increase over that 7-year period in rough sleeping based on the national snapshot counts. In 2018, there was a response that the rough sleeping strategy came along, and as part of that, the rough sleeping initiative, and things started to improve. You can see that curve starting to come down. But then COVID hit, and as I've said, that the Everyone In campaign was announced in March, and it was on March 26th, which was a Wednesday, and local authorities were given the mandate to identify all rough sleepers, move them into emergency accommodation by the weekend. So that's about 2.5 days to do what's not a small feat. and yet by mid-April it's estimated that 90% of that population had actually been put in emergency accommodation. And there are some disputes about the credibility of the figures and the accuracy and so on, but it's pretty indisputable that there was a significant and rapid impact, and it kind of highlights two things I think that are noteworthy. One is what is possible in this particular extreme example of health inequalities. What was possible when there was government will, funding, and the freedom for rapid collective action towards that common goal of getting everyone in. Things happen, and things happen very quickly. And the second thing is it's really helped to highlight the scale of the problem. So that the pre-COVID estimates of 4,000, or less than 4,300 rough sleepers, based on the national snapshot method. But we know that rough sleepers are a pretty small proportion of the overall homeless population. And the estimates are that everyone in has housed approaching 15,000 people into emergency accommodation. So it was clearly accessing some of the other groups that are shown in that graph there, the sofa surfers, people in unsuitable temporary accommodation, squatters, people sleeping in tents and cars and so on. So it's really shone a light on the problem, and it's highlighted that despite the terrible circumstances, there is some good that has happened, and there's an important time now to make the most of that and make sure that we don't kind of kick everybody back out onto the street and revert to where we were before. And there have been positive noises, and there's been funding made available, and it sounds like it's quite promising. But the research we've been doing, we've been speaking to stakeholders who work from frontline services to service management commissioners up to national policy. And what we've been told with our recent engagement is that quite quickly after that initial intake, things started to get worse. And so homelessness started to increase. People were newly homeless. After the everyone in there were new people taking to the streets. Some of the protections that were afforded under the everyone in policy, such as the ban on landlords evicting tenants who were in arrears, the protections afforded to immigrants who had no recourse to public fund status, they've now all been lifted. And the next 6 months doesn't look particularly promising. We know that furloughs ending. We've been told we're entering a recession, the worst for 300 years. COVID is ongoing, but there's no obvious end in sight for that. The economic fallout of Brexit is yet to be seen, but it's hard to see that's going to be a particularly positive thing. And in light of that future, what can we say about public funding? Well, the rhetoric is good so far, but under those circumstances, it would be quite optimistic to think that public funding to support this kind of policy isn't going to be effective. I guess time will tell. So that's one example of, as I said, a very extreme form of health inequalities. But going back to the social determinants model, there's all of these factors that collectively influence all of our health, regardless of where you're on the social ladder. All of these factors come together to sort of have a powerful impact on our health and well-being and behaviour. And one of the areas we've done quite a lot of work in is around natural environments and health. So think about the neighbourhood environment, your living environment, the things you interact with on a daily basis. And so I'll just spend the rest of my time just focusing on some work we've done looking at this relationship between exposure to natural environments and health. And what we've seen is that there's pretty convergent evidence that exposure to natural environments are good for our health. We tend to prefer them, we seek them out in times of stress, often for recreation, relaxation. And through our work on the Phenotype project, which was a large EU-funded project a few years ago, within that there's loads of studies that we did using different sorts of methods, collecting different types of data in 4 different European countries. And that they've often shown us what this apparently protective effect of being in and around green environments. And so here's a few examples. This one is all-cause mortality, and what this figure is showing is that as we move from neighbourhoods with the least amount of natural environment, so less than 25% of the area is natural, up to the most environment, we see this gradient of reducing age standardised all-cause mortality, so lower death rates in the most green areas, and that's adjusted for other sorts of confounding variables you might think could explain that relationship. data from our sample of nearly 4,000 adults from 4 European cities, one of which was Stoke-on-Trent. That showed us that the more people visited natural environments, or when people visited natural environments more, there was a positive, apparently positive association with their mental health and vitality. And it was a small effect, but it was positive and it was significant. And at the population level, these kind of small effects do actually matter. And similarly, we saw something for cognitive function. We used a trail making task as like a simple measure of cognitive performance. And what we saw is that for every 100 meters further away from their nearest natural environment somebody lived, there was a 1.5% worsening in their cognitive performance. They took longer to complete the task. So further distance from your nearest natural environment, worse cognitive function. That's the general direction. And in the context of this talk, equigenesis or equigenesis, I never know which, is a term that is quite useful. It's a useful concept to consider. And it's a term that was coined by Richard Mitchell and colleagues from Scotland. And it's used to describe what we often observe, which is the health benefits that I've just described of living near nature, of being in around urban green space, are the strongest in the most disadvantaged groups. And again, we saw this multiple times in our phenotype data. So a couple of examples. So we asked our sample, so it's a subsample of our European population of about 400 adults across the 4 countries. They were asked to wear a smartphone for a week, and that smartphone, the GPS unit and the accelerometer in the phone, collected real-time objective data over the week. It allowed us to see that the more time people spent in natural environments, the better their mental health. And interestingly, that was completely mediated by stress. So the statistics were telling us that people spent more time in natural environments, they got a stress-reducing benefit, and that led to their improvements in mental health. And importantly for equigenesis, that appeared to be strongest in the low to medium educated groups. So education is quite a good, stable indicator of socioeconomic status, so it kind of backs up the idea of the strongest effects in the most disadvantaged groups. Similarly, data from the Born in Bradford cohort. These were data from about 7,500 pregnant women, and it showed us that women who lived in the greenest areas were 18 to 23% less likely to report depressive symptoms than those who lived in the least green areas. And when we stratified that analysis by education and split the sample, we saw that that association was only observed in the lower educated women, not those who were more educated and higher socioeconomic status. So again, equigenesis example. And we saw a similar thing for birth rates in the Born in Bradford cohort. Data from about 11,000 live births showed a positive association between birth rate and residential surrounding greenness that was strongest in the most disadvantaged neighbourhoods. And so that's good. That's telling us that natural environments offer us a mechanism, one of the ways in which we can start to tackle health inequalities, because we see those who need it most can actually get the biggest health benefit. And yet we also see inequalities in access and perhaps use. And there's data from 2010 from CAVE that showed this inequality whereby those in the poorest areas tended to have far worse access to green space. We saw in Stoke-on-Trent through our phenotype data that for those of you not familiar, Stoke-on-Trent, there's quite a lot of deprivation across the city, and yes, it's incredibly green. So access to green space in our sample was really good. So on average, people lived 100 meters from the nearest natural environment that was publicly accessible of a good size. And yet of that sample, just over 40% said they'd never used it. They never engaged with that essential public health resource on their doorstep. And there's various reasons why that could be. But what it's telling us essentially is that we need access to it. We need to live in greener neighbourhoods, but we also need, as well as the sort of urban greening and infrastructure, we need participation, engagement activities to get people out and using those spaces for the maximum benefit. And I'll end on this slide, and it's the idea of thinking about urban green space as a triple win, and it kind of starts a link with the environmental sustainability, climate change agenda a little bit. And it's been described as a triple win for environmental sustainability, partly because some of the things we would do to increase exposure to natural environments, like urban greening, have knock-on benefits for the environments. They start to mitigate some of the disbenefits of urbanisation and reducing air pollution, noise pollution, and so on. We've seen from the data I've presented, it's good for health, and it can help to reduce inequity and health inequalities. And then the final thing I'll leave you with it is a quote from I suppose the godfather of health inequalities research, Professor Sir Michael Marmot, who described the twin problems of social inequalities and climate change. So they have to be tackled at the same time. But he identified those the two main things we've got to grapple with to create a society that's just and sustainable. It's going to actually benefit our health and the future generations. Okay, so with that, I will stop talking, and I thank you very much for listening, and I'll hand over to Aoife.
Thank you very much, Chris. So I'm Aoife Healy, Associate Professor within the Centre for Biomechanics and Rehabilitation Technologies. So I'd just like to firstly introduce you to our centre, which focuses on improving health, quality of life and healthcare provision by solving complex biomechanical issues related to diseases which are a public health concern. We aim to understand advance the understanding of musculoskeletal biomechanics through highly innovative and integrated approaches. So in part of this SDG Goal 3, there are a number of targets laid out, and my research falls within these two targets, 3.4 and 3.8. So 3.4 focuses on reducing mortality from non-communicable diseases and promoting mental health, and target 3.8 looks at achieving universal health care coverage for all. So for this presentation, I'll be discussing the focus of my research, which is assistive technology for mobility, and how this relates to Goal 3 for healthy living. Mobility assistive technology includes a wide range of things like wheelchairs, crutches, scooters, footwear, insoles, and prostheses. These devices are designed to enhance people's quality of life and provide important functional benefits to assist them in their daily activities and helping them to maintain their independence. I will be focusing on two aspects of my research which come under this topic. The first, looking at techniques and technologies relating to the protection of the diabetic foot and service provision for clinical management. Firstly, I'll introduce the topic of AT, assistive technology. Then I'll provide an overview of the global prevalence of diabetes, how diabetes affects the feet and therefore mobility, and some of the research I've completed in this area. I'll then talk more about the service provision related to mobility assistive technology, and specifically around the provision of orthotic services within the NHS in the UK. So my research focus is to assess the mobility assistive technology, which is one of many subgroupings of assistive technology. AT, or assistive technology, is an umbrella term covering the systems and services related to the delivery of assistive technology products. Assistive products maintain or improve the individual's functioning and independence and promote their well-being. Globally, more than 1 million people need one or more assistive products, and with an aging population and an increase in non-communicable diseases, more than 2 billion people are predicted to need at least one assistive product by 2030, with many older people needing 2 or more devices. Diabetes is a non-communicable disease. These are diseases that can affect anyone, anywhere, regardless of age or gender. These diseases are non-transmissible between people, and premature onset and deaths from these diseases are largely preventable. They tend to be long duration and are linked to a number of factors, a combination of genetic, physiological, behavioural and environmental factors. So things like tobacco use, excessive alcohol use, physical inactivity and unhealthy diets can all increase the risk of dying from a non-communicable disease. The global prevalence of these diseases is rising steadily. This rise is linked to population growth, ageing population, and lifestyle changes associated with urbanisation. Non-communicable diseases are projected to account for 52 million deaths in 2030, representing 75% of all deaths. The probability of dying from one of these four main types of non-communicable diseases has reduced globally by 18% in the last number of years, from 2000 to 2016. The rapid decline was most seen in chronic respiratory diseases, which are down by 40%, followed by cardiovascular disease and cancer, which are both down by 19%. Diabetes, however, is showing an increase in 5% in premature mortality. So looking at the global prevalence of diabetes, we can see that it is rising steadily. And by 2045, it's predicted that there'll be 700 million people in the world with diabetes, which is an increase of 51% from 2019. These increases are predicted for every part of the world, with the largest increases seen in what is termed the Global South, South and Central America, Africa, Middle East and North Africa, and Southeast Asia. The greatest increase is predicted for Africa, where currently it's estimated that 3 in 5 people with diabetes are undiagnosed. Diabetes can lead to a number of long-term complications and is a major cause of lower limb amputation. Every 30 seconds, somewhere in the world, a limb is amputated related to diabetes. People with diabetes are 6 times more likely to undergo an amputation than people without. And approximately 85% of these amputations are preceded by an ulcer, meaning that once an ulcer is developed, it's extremely important that it's urgently cared for with the right appropriate care. A recent report has shown that expenditure on diabetic foot care in England accounts for more than the combined cost of treating both breast, prostate and lung cancers. And more than 90% of these costs are for ulcer care. They calculated that if the NHS could reduce the prevalence of diabetic foot ulcers by 1/3, that the gross annual saving could be more than £250 million. So how can we reduce the instances of diabetic foot ulcers? The most common causal pathway to the development of diabetic foot ulcers is the accumulation of trauma, neuropathy and deformity. Neuropathy leads to a lack of sensation and sweating and wastage of muscles in the feet, while deformity can be things like claw and hammer toes and bunions. The focus of our work in reducing diabetic foot problems is focusing on reducing trauma. Our work focuses on correctly fitting footwear and appropriate footwear insoles. Due to the issues I've outlined with neuropathy and deformity, these can lead to people with diabetes having very high pressures under their feet, which can lead to trauma, and that can lead to ulceration. It has been shown that with a comprehensive diabetic foot risk assessment and education in foot care, which is based on prevention, education and a multidisciplinary team care, that this can reduce the incidences of complications and amputations by up to 85%. So my research in the area has focused on looking at different footwear and insoles and how they can be used to prevent and treat diabetic foot ulcers. This first study looked at what we call rocker sole shoes. So these are shoes with this rocker aspect to the front of the footwear. And the purpose of this is it allows you to quickly move over this area when you're walking. And by quickly moving over it, you reduce the amount of force that is applied to that area and you offload that area, which then reduces the likelihood of trauma and the development of ulcers. And what we wanted to do with this study was to look at the effect of this on balance for people with diabetes. So people with diabetes can have some balance issues, so therefore we want to make sure that any interventions that you apply are not going to hinder balance any further, as you could potentially increase the risk of falls. So in this study, what we did was a comparison between this footwear with this rocker sole and the same type of footwear but with a flat sole. And the results were really promising, showing that this rocker did not have any effect on balance. Another study that I completed was looking at different insole materials for reducing plantar pressures. So plantar pressures are the pressure between the foot and the supporting surface, which in this case is the insoles within the footwear. And how we measure these plantar pressures is the use of these types of sensors which placed within the footwear. So the image on the right is an example of a plantar pressure profile. We can see here how the red indicates a high pressure and the blue is more lower pressure. So in typical gait, when we're walking, what we tend to see is as you load your foot, your heel contacts the ground, and we tend to see these higher pressures in this area as your weight has been transferred onto that small area of the foot. Then as you progress forward, it gets transferred to other areas. And again, as we push off at the end of our step, we see some higher pressures here at the top on the toes. So what we want to look at is what can we do to help reduce higher pressures in people who have complications such as diabetes. So I want to look at what materials would be most effective to reduce these pressures. And while it might be kind of intuitive to initially think, put something in the footwear that's really, really soft, that'll help. if you put something very, very soft, what will happen is once you stand on it, it'll completely flatten, and then it won't offer any kind of reduction in pressures. So the purpose of this study then, we compared 4 different materials, actually 2 materials of 2 different densities, to see how they affected pressures. And here's just an example of some of the results we got. So here is the person walking, wearing the shoe on its own with no insole. And then this is an example of one of the insoles that we used. So we can see here, just by the color change, that you can see there's a reduction here in the pressures that we're seeing in the heel. And again, in the big toe here, there's a reduction in pressures. So the results of this study were really promising for these materials and their use in diabetic footwear insoles. Some of the other research I've completed has been a number of systematic reviews, which involve looking at all the studies that have been conducted in this area and evaluating them and looking at their findings as a whole. So I've completed 2 reviews that focus specifically on diabetic footwear, looking at prevention and treatment. And I also completed a wider review looking at footwear or prosthetic and orthotic interventions in a wider area. The most recent review involved reviewing a total of 15 studies, which compared different types of insoles and different kinds of footwear that were used in the treatment or prevention of diabetic foot ulcers. And we had some promising results in that study, which showed some evidence of superior results for these types of interventions, which resulted in lower incidences of ulcers and also lower incidences of relapse from ulcers as well. So the findings for this review were published within the WHO standards for prosthetic and orthotic interventions. The aim of these standards is to ensure that prosthetic and orthotic services are people-centered and that they're responsive to every individual's personal and environmental needs. The standards advocate for the integration of these services into health services under universal health coverage, and the implementation of these standards by countries will enable them to fulfill their obligations under the Convention on the Rights of Persons with Disabilities and towards SDG Goal 3. The standards provide guidance on the development of national policies, plans and programs for prosthetics and orthotic services of the highest standards. These standards are produced by the Global Cooperation on Assistive Technology, or GATE for short, within the WHO. This initiative was developed or established in 2014 to improve access to high quality, affordable assistive technology for everyone, everywhere. And it focuses on 5 Ps: people, personnel, provision, products and policy. And this is to ensure that all aspects of access to AT are considered. For example, you not only need to be able to access the product that you want, but you need to have the right personnel involved to make sure that the right product is being chosen and that the user can be trained how to use it. So I'll now move on to another aspect of my work, which is on service provision for clinical management. So if we first look at mobility disability within the UK and look at the statistics, we can see that mobility is the most prevalent disability in the UK, with a percentage of 48% of disabled people having some form of mobility impairment. If we then break it down to the further age groups, we see that within that 48%, the highest proportion are state pension age adults at 67%, followed by working age adults at 40%, and children at 21%. So as I mentioned, mobility products include a diverse range of diabetic footwear, and also other things like post-operative footwear, ankle foot orthoses, prosthetics, crutches, wheelchairs, spinal braces, wrist splints, and upper limb prostheses. So they are products that assist people in with a mobility limitation or impairment in sitting, standing, walking, or transportation within their environment. And as you can see, due to the wide range and levels of mobility impairment, there's a huge amount of products. These are just naming just a few that would sit under the term of a mobility assistive product. So these products are provided by a wide range of clinicians, including physiotherapists, occupational therapists, podiatrists, orthotists, and prosthetists. And many of them are also widely available on the high street and online. So I'm going to focus on the work that we completed looking at service provision within orthotic services in the NHS. So orthotic services in the wider scope of mobility AT, they provide whole body assistive technology for mobility. So things like helmets and spinal braces and neck braces, wrist splints, AFOs, footwear again, like the diabetic footwear that we discussed earlier. So when you think about how globally people access these products, it's a real issue. There's a real lack of access. And currently only 1 in 10 people who need a prosthetic or an orthotic device have access to it. Orthotic service provision within the NHS is not well understood, and many reports that have been published by both the NHS and other organisations highlight the issues within the service and the potential benefits if these services were improved. Due to the lack of data available in regard to the NHS orthotic services, we currently don't know how many people in the UK need access to orthotic devices. It's currently estimated that there's approximately 1.2 to 2 million people who use orthoses in the UK. The NHS orthotic services has previously been described as a Cinderella service, which is poorly understood and not high on any list of priorities. And previous studies have estimated for every £1 that will be spent on improving these orthotic services could potentially save the NHS £4. The potential benefits of improving these services include clinical benefits for patients, financial benefits for the NHS, and economic benefits for the wider economy. Improvements in service provision are particularly important considering things like we discussed, the growing population, aging population, and rise in non-communicable diseases. So the global need for these type of services is really going to increase in the coming years. So to get some more information on these services, we completed a study to investigate the quality and quantity of these services within the UK. And this study was conducted by Nachi, who leads our centre, Nikki Edison, who is a research fellow within our centre and also who is orthotic manager within the Royal Wolverhampton NHS Trust, and myself. So how we did this is in 2017, in early January, we sent out a Freedom of Information request asking questions about service provision to all trusts in England, Scotland, Northern Ireland and Wales. Response rates for this were 61% overall. We had the greatest response from Wales and Scotland at 86%, and then Northern Ireland at 60% and England at 58%. So when we looked at the results, we wanted to really look at determining if where you lived affect the service you would receive in these services, and unfortunately it did. We found very large discrepancies in the waiting times for appointments, and generally they were quite long. So here we see a breakdown of the services across different regions of the UK. So we have England broken down into 9 different regions, Northern Ireland, and we don't have any results from them, they didn't provide the information on these questions, and Scotland and Wales. And on the bottom here we have the number of weeks that they had to wait for appointments. So the black dots are representing a routine appointment, the median for each of these regions of the UK, and then the lines represent the minimum time people have to wait and the maximum time, and how that, so the minimum for one trust and the maximum for different trusts in that area. And the green squares are representing the waiting times for urgent appointments, and again the minimum and maximum. So for routine appointments, we can see that in Wales they have the longest median wait, so people were on average waiting 10 weeks for a routine appointment in Wales, but the longest waits were seen in the English trusts. So here in the Northwest, one trust was looking at a 34-week wait for an appointment. In the West Midlands, here 23, and some of the other ones again around the kind of late teens. So these was quite long waiting times. And if we look at the urgent waiting times, again the Northwest were one of the longest, along with West Midlands and North Yorkshire and Humber, which were kind of between 7 and 9 weeks waiting times. And what's interesting is you can see that, for some trusts, people were waiting longer for an urgent appointment than some people were waiting for a routine appointment. So you can see how different those were in different regions, and within different regions the same. We also saw large variations in the length of appointment times. So this ranged from 18 to 40 minutes. And even at that, the 40 minutes is still considered quite a short appointment time when you compare it to other allied health professionals like podiatrists or physiotherapists. And there was large variations in patient entitlements for orthotic devices. So in some trusts, a person was entitled to 1 pair of footwear or insoles a year, or 1 pair shoe size for children. Some had 2 or 3 a year, and others said they just supplied them as needed. So this is very different. And we also saw large variations in manufacture lead times for people to actually get these footwear after they were made. And again, a lot of these times were outside what would be considered reasonable timescales to receive these products. So that, in combination with these patient entitlement differences, really shows that the service you receive does very much depend on where you live. So while the survey generally showed very similar results to previous surveys in some of the issues that are in the service, we also did find that there are some improvements that have been occurring. And these include the ability for GP referral and the inclusion of orthotic services within multidisciplinary clinics. So, as I said, we only had a 61% response rate, and then also some of the responses we received had very little information in them. They didn't answer all the questions. So this really didn't enable us to provide what we'd hoped would be a complete national picture of orthotic service provision. So it's highlighted gaps in data capture within these services, and that prevents proper service evaluation. The NHS needs to establish kind of appropriate processes in regard to this quality of service provision so that we can enable improvements in clinical management and to get good value for money. So there have been huge changes in orthotic service provision recently, as there have across all services within the NHS due to this, the current COVID-19 pandemic. So many of these services had to close for a number of weeks, which would have affected their waiting lists. And also many of them are now implementing telephone and video appointments into their service. So they're reducing the amount of patients that are coming into the clinics. And this is something that we're currently looking at. Nikki is leading a project where we're going to evaluate from the Orthos point of view how our services have been affected by the current pandemic. So to finish, I'd just like to come back to this WHO GATE initiative that I spoke about earlier and some work that we're currently involved in. So in 2016, they published the Priority Assistive Products List, which listed the 50 priority AT products for the world. And this list was published with the aim of creating awareness in the public, mobilizing resources, and stimulating competition. So WHO are encouraging all countries to develop their own country-specific list, and the UK will be the first European country to develop their list. The survey used to develop the list is currently being run by the British Assistive Technology Association, and this survey is currently live. It allows those using and developing AT services to contribute to the survey, and so everyone can be involved in developing this list so that UK policymakers, users and service providers can plan, procure and provide even more effective access to these services than we currently do. I would encourage everyone with an interest in AT to look up the survey online and complete it. So from Chris and myself, I'd like to thank you all very much for listening, and we're now happy to answer any questions you may have.
Thank you, Aoife, and thank you, Chris. Currently, no questions have come through. So I just wondered, Sally, if you were able to share with the audience, what are the university's sustainability goals at the moment?
The university's sustainability goal really is to achieve this sort of carbon net zero position by 2030, but also to be real thought leaders in the area of sustainability and the other sustainable development goals like we've been hearing this evening. So obviously that really then is down to people like Chris and Aoife, who obviously are doing the research and who are then able to share that with us and to then put that into the syllabus, into the curriculum, and to then share that with our students and with other people. So it's really important that the university is involved in sharing things through the development of the curriculum and through the research strategy. Also, our estate is a huge opportunity for us to make changes. So every building that we build in the future will be will have a net carbon zero position over its initial life, which is about 15-20 years. And we'll also make improvements to all of our buildings so that every time we do an upgrade to a building, we'll make sure that we make it more sustainable in terms of energy. We'll improve insulation, we'll improve energy systems, and we're also looking to stop using gas and to turn to electricity and to take that electricity from sort of greener sources. So whether that's generating it ourselves by putting photovoltaic cells onto the roofs of buildings, or maybe one day even having like a wind farm on site, or taking green energy from other suppliers, and that's what we intend to do. So taking energy from renewable sources. And then the third thing which the university wants to do around sustainability is to involve everybody in better choices, so that when all the things that we buy to consume on site, whether it's food, whether it's the sort of furniture that we buy, or that we make sure that people are making good choices, and that isn't about the university sort of issuing like telling people what to do, but just helping them to understand what the consequences are of different choices, and making sure therefore people are informed in what they do, and working with suppliers to understand their supply chains, so that we can understand how sustainable they are. So that's the three things we want to do really around sustainability: is the academic strategy, things we can do with the estate, and things that we can do around the things that we consume. Oh, and travel obviously as well. Travel obviously is a big thing at the moment. Unfortunately, the way that things have changed post-COVID is that all of the really good things we might have been doing around travel, around using public transport, around car sharing, obviously are not seen as being a good thing at the moment, and that's very disappointing. So hopefully once all of this settles down, then we can get back to a situation where people are able to also make good choices around travel, which are sort of like more sustainable. So thank you very much for that question.
Thank you. Chris, we've had one come through for yourself. Thanks for the evidence on access to green space as a health inequalities intervention. With COVID and other social financial impacts, it's potentially that we're going to see a big rise in mental health problems. How can the evidence be translated into policy to deal with mental health and other health inequalities?
Okay, that's big, isn't it? Yeah, so I suppose trying to break it down a little bit. So that there is, as I've set out a bit, there is good evidence that exposure to natural environments, it benefits mental health, and the evidence is probably stronger for mental health than it is for physical health. And there's been for a long time, there's been services, mental health services that use trips to often group visits to around here, Eight-Bell Park and other sort of natural environments as part of the therapy. It's sort of an opportunity to, in a non-clinical setting, to engage with mental health populations and clinical groups who may not otherwise get to engage with well. And there are, as well as the group and the therapeutic benefits, there is that engagement with natural environment which can have benefit. Translating into policy is a tricky one. There has been natural environment prescriptions that they have been used, as in GPs, sort of giving a kind of a prescription to go and do things. There has been talk of a natural health service in the past. I suppose the evidence is there, and there's a lot of it. There's a lot of evidence for the benefits of prevention and for treatment. So in terms of turning it into policy, it's just, I suppose, it's lobbying it and making the case and presenting the evidence in the best way possible to try and influence those who are affect the health service. And I suppose thinking slightly bigger picture, the advancing, there was a green paper published last year, July 2019, which really highlighted the growing interest in prevention, with the recognition that the current health service pressures are not sustainable, the need to prevent disease rather than cure it. And in that light, and the natural environments, the green paper was very much suggesting that's the way forward we need to go, and natural environments can clearly be a big part of that. So it shows there is recognition high up. It's just how to translate that into policy is a tricky one. It's probably above my pay grade.
Thank you. Thanks for the really interesting presentations. Dr. Healy, if there were 3 things you could change in NHS foot care services tomorrow, what would you change and why?
Oh, that's a good question. 3 things that change in the health service. I think that for any kind of service improvements, you need to have the data to know what works and what doesn't work. So I think definitely having better data capture within the service will be really useful. And we need to know how many people need these services, which again will link into like the AT survey that I spoke about at the end. because we need to know how many people currently need it so that we can predict, you know, if we know we're going to need more of these services in the future with the growing population and aging population. So we definitely need to know that. And I think there needs to be greater understanding of things like these patient entitlements. So I don't think, you know, we need to have this equity of care within the different trusts so that everyone can access the same types of devices and has that access. And I'm trying to think of the third one. I'm drawing blank now. I think I'll just stop with two. I've got two.
Okay, just following on from that, Aoife, we've got a community nurse that's just asked a question about the compliance of the use of the rocker sole. She's finding that they're finding that compliance is an issue. Also, many ulcers we treat are on the ball of the foot. Is there anything that reduced this pressure more so than the rocker sole?
First thing around compliance, and yeah, that's definitely something that a lot of clinicians talk about, and there's a lot of research, because when you look at a lot of these footwear, they do look very different to standard footwear, and people don't want to look different. So it's about trying to make them more kind of aesthetically pleasing for people, and to try and work with your patient. I mean, just don't tell them you have to wear this. You know, there's different designs, there's different ways you can kind of adapt it to suit their needs. So I need to look at that. And for anything around the midfoot, for ulcerations, I know a lot of the research we've looked at, and mostly footwear is more for prevention of ulceration. A lot of the research for the treatment of ulcers once they've developed is more looking at things like total contact casts or removable cast walkers, which are more effective of offloading the ulcer to allow the ulcer to heal. And once it's healed, then you think more about the footwear interventions that are going to prevent any relapses in ulceration.
Thank you. It's a question for both of you here, so I don't know if Chris, you want to answer, and then Aoife, or just one of you, but from both of your work, how can technology help in reducing the inequalities that you've both spoken about?
Yes, there is increasing room for it. I suppose a few years ago, probably not that many years ago, then things like smartphones and mobile phones and sort of providing services and support to people who may not engage with other mainstream services was actually potentially going to widen inequalities, because the technology was not pervasive and there was that inequality in access. Whereas now, mobile and smartphone usage is so prevalent and widespread that hopefully that would not be the case anymore, and it may well offer a way to engage with those groups who don't engage with typical health services. And we know that for things like screening services, we've done a lot of work around NHS Health Check, which is about prevention of cardiovascular disease. We know certainly in our local area that uptake is significantly lower for people living in a more deprived area. So that service may not be doing anything to actually reduce health inequalities in the local area. We could use technology to remove in that example, we can use technology to remove the need for an in-clinic appointment, do things remotely and virtually, try to overcome some of the, I suppose, logistic barriers which often do prevent that engagement of the harder to reach, and a lot of people hate that phrase, but I don't know what else to use, the harder to reach populations who to that end.
Okay, I think we've just got time for one last question. Chris, again, this is for you. With PHE currently being disbanded and moving into the National Institute for Health Protection, what does this mean for the research that you undertake, and do you think that this is a wise decision?
Yeah, I was not happy when I saw that headline. It took me a few hours to realise that it was actually credible and had substance, and I was just swearing for a while. And so I'm not a supporter of the decision necessarily, but then I don't know the workings or the thinking behind it either, because it was announced over the weekend, as far as I can remember, and we know that the health protection bit will be part of this new National Institute of Health Protection, but there's a whole raft of other services that Public Health England manage and provides that haven't yet been, we don't know what's going to happen with those. I think we will know by March or April next year. Not a huge fan of the decision, but I say that not knowing what the actual grand plan is, and I don't know who does know the plan. Hopefully the implications won't be too great. My first fear, obviously, we've done, as I said, a lot of work around NHS Health Check, which is the biggest CVD primary prevention programme of its type in the world. PHE manage it. We've been researching it for the last decade. We've got quite a big stake in that as a programme, as an academic group who are engaged in it. It appears that that's going to continue. The PHE and those aligned with the group are talking about how to improve this over the next 10 years and use things like technology to increase its spread and help to reduce health inequalities. These are the previous questions we're getting at. So it appears to have a future, which is good, and my hope is that that will apply for other areas of work that PHE do, and that things won't sort of won't come to a halt because of that restructuring. And I suppose, sorry, just to waffle a little bit longer, given that there is apparently this national push on prevention and obesity prevention as a means of reducing risk of severe and life-threatening COVID symptoms, then you would think that the other functions of PHE that are not just about health protection would also have a role to play and will have a future.
Thank you both. Just to let our audience know that any unanswered questions tonight, we will get Chris and Aoife to answer them, and you'll get those sent in an email. I'd like to hand back to Sally now to close this evening's talk.
So thank you, first of all, to Chris and to Aoife. That was a really great session. Thank you for following up with all those questions as well. And that was a great start to our new Profs in the PAV. I just wanted to know, do we have a Twitter handle for Profs in the PAV? Can we go? Do we do hashtag Profs in the PAV so that we can let people know about it? I'll let somebody come back on that.
PAV, yeah.
Okay, thank you. So also thank you to the audience. Thanks very much for joining us this evening. I know it's been a bit unusual that we've not been in a sort of to us be together, but I hope that you've really enjoyed this evening as I have. Looking forward, second in the series, 2nd of November, we're turning to the subject of governance in a time of crisis. What could go wrong? And we'll be hearing from Associate Professor Simon Smith and Associate Professor Joanne Turner, who will be our presenters that evening. So again, thank you very much to everybody. Thank you to all those who have also organised this and made it possible and been able to put it online. So and yeah, have a good evening. Thank you very much.